Hi everyone. Sorry we are starting this a couple of minutes late. We are having a presentation today from new colleagues. Actually, it's actually their first meeting today with us, and I'm sure that we are having a very nice meeting. So I think Kevin is already letting everyone show their screen and also open their mics for comments. I'll try to ask a couple of the senior surgeons that are on this meeting today to comment on the case. So if you are able to comment, I'm going to call you. And also, if you want to, anyone that's not called upon but want to make any comments or ask any questions, please do so in the chat, and we will be able to read them out loud and maybe open a mic as well for you, so we can have this meeting going. So I think that if you already have your screen ready to present, you may do so, and we can start.
We have the screen ready, but I don't know if you can see it.
Sure.
Let me see. No, we can't see it. I don't know if you, so, but you are able to share, right?
Exit and
Yeah.
share your screen from.
And just to make sure, you are both there, right? Dr. Kelsey and Dr. Tori?
Yeah, we're both here.
Great. So for those who don't know Dr. Kelsey and Dr. Tori, they come from Emory Grade Memorial Hospital. They're both SCC and AAST ACS fellows, and they're going to present the case for us today. Yeah, we can see the screen now, your computer screen.
Screen on.
It's a bad weather there, isn't it? It looks gray. I'm getting depressed. Oh, no, that's better now. From gray to sunny. That's very interesting.
So I'm Kelsey, and I'll be starting off. I'm Tori. We're both surgical critical care and AAST ACS fellows at Grady and Emory. And today we'll be doing some patient case presentations on subclavian artery injuries. The objectives for this is to review open operative techniques for subclavian artery injuries, to discuss initial management of suspected subclavian artery injuries, and then to compare and contrast different endovascular techniques to subclavian artery injuries. So for open approaches to subclavian artery injuries, frequently an open repair is associated with a higher morbidity and mortality, and that's because usually the subclavian artery is difficult to expose quickly and takes longer to expose it because of how deep it is. There's several operative incisions that have been described, from a median sternotomy to a limited sternotomy to a thoracotomy, a supra or infraclavicular incision, or trapdoors. Some patients require more than one incision for both distal and proximal control. And then in the unstable patient, sometimes the artery needs to be shunted so that we can further stabilize them and bring them back.
Surgery can be performed through a median sternotomy, super infraclavicular, or via thoracotomy with the trapdoor approach, depending on the location of the subclavian artery injury. Controlling the proximal injury can usually be achieved by a supraclavicular incision or a median sternotomy based on the location of injury. But previous studies had demonstrated that a combination of a median sternotomy and a clavicular incision can provide the best exposure, and then also avoids a trapdoor incision, because this can be accompanied with severe pain, excessive bleeding, and then can cause some respiratory complications as well. The left-sided subclavian artery can be exposed most easily through the supraclavicular incision or an anterior lateral thoracotomy with a trapdoor incision. This is because it arises directly from the arch of the aorta, and it doesn't typically traverse above the clavicle into the neck like the right subclavian artery can. The first portion of the subclavian artery also lies very deep, making it difficult to expose surgically. So the optimal approach to the proximal left subclavian is usually through the anterior lateral thoracotomy through the third or fourth intercostal space. A supraclavicular approach or a median sternotomy can also help gain access to this proximal portion of the left subclavian. And then exposure of the axillary artery with extension of the infraclavicular incision through the deltopectoral groove can help us get that distal subclavian artery control. The right subclavian artery needs to be entirely open through an extrathoracic approach or a median sternotomy. The proximal right subclavian artery is usually best approached through the median sternotomy, and obtaining the distal control requires extension of this incision through a supraclavicular incision.
So for our first patient, this was a 23-year-old male who was status post to GSW to the right chest and the left back. Prior to arrival in our trauma bay, he had received 2 units of whole blood and TXA. For our primary survey, his blood pressure was 80s over 30s. He had a heart rate of 107 and he was satting 94%. His airway was intact. He did have diminished breath sounds on the right side. He had a pulseless right upper extremity and easily palpable pulses on the left upper extremity. His GCS was 15, and he had a ballistic wound to the right chest and left back, which you can see demonstrated on the diagram. In our trauma bay, we gave him 2 more units. 2 more units of whole blood, and his blood pressure improved to 130s over 60. For his neurovascular secondary survey, it was significant for his left upper extremity. He had intact motor and sensation. In his right upper extremity, he had diminished motor and sensation, and then he had no motor or sensation below the nipple line. This was our chest X-ray, and you can see where he had where his 2 ballistic wounds were, and he significant for a large right hemothorax. We placed a right-sided chest tube, which put out 1.2 liters of sanguineous output. And our repeat chest X-ray looked like he had resolution of his hemothorax. Given his stability, we elected to go to the CT scanner. And this is the CTA that we obtained. You'll see that he has his right subclavian artery with abrupt cutoff and with a short segment of reconstitution. And then he also has a T2 to T3 spinous process fracture. And a retained hemothorax.
Can I ask a question? According to you, where is located the subclavian injury here? And what zone? 1, 2, or 3?
It was in the median third, so the zone 2.
Okay.
Yes, sir.
Okay. So can I pause you for a second?
Yes, sir.
And do you want me to pause along the case, or do you have any specific spots that you're going to stop to so we can discuss any parts with the panelists?
Oh no, you can pause you can pause
Okay.
if you want me to.
Okay, perfect. So I'm going to ask for some opinions here from the panelists as well to make sure we are going to have this nicely discussed. So, Dr. Rodriguez, you want to start? I want to ask you about I mean, after the CT scan, and this patient now has an injury to the middle third of the subclavian artery. What else would you consider? What else would you consider while trying to figure out what's the best management here? Would you consider the anatomical location to maybe try something endovascular, or maybe going for an open surgery directly? Would you consider anything like this?
Yeah, I have 2 comments. I'm going to start with the anatomy, which you show very nicely, the metriades. I thought it was better pictures, but it's 2 good pictures. It's very important to know the zones, because the zones is going to, and the size is going to determine what you're going to do. And of course, it's very important also to see the status of the patient, because if the patient is in extremis, you have to operate. You have to go to do surgery, you know? Because usually endovascular case, in the best of my knowledge, endovascular treatment of this is not necessarily in circumstances with total transection or sanguinated the patient. There's no role for that, I understand. So the zones is very important. Zone 1 is the zone, you know, why you need to know that is between the scalenus anticus, you know, that's where the artery is behind, scalenus antiquus, scalenus medius, to the notch of the sternum. That's zone 1, or proximal. Zone 2 is between the scalenus and distal. Okay, there's zone 2 behind the scalenus. That's zone 2. Where is the sacral plexus is behind that. And zone 3 is distal to that. Why is important is because if it's zone 1, you have to do mid-sternotomy on the right side, and the mid-sternotomy and prolong perhaps to do a supraclavicular to get proximal distal control. If you are in zone 2, you don't have to do mid-sternotomy in the right side. You just do on top of the clavicle, and you can approach the subclavia right there. Okay, it's a zone 3, the same thing, supraclavicular. Now left side is different. Hopefully you don't have left side, because left side you have to do, as you said, left anterolateral thoracotomy, to get proximal control. And perhaps I never have to do you're talking about the book, whatever they call that incision, combined with the supraclavicular, but so the right side is much easy. My understanding is endovascular usually is used for partial injuries or injuries, or most of the endovascular cases that I am aware are mostly complications, but they have a pseudoaneurysm or something like that. But most of the cases, despite you can tell me recently they're using more endovascular, of course, there's more technology, better people doing that. But blunt trauma, just to one statement you haven't done yet, is very rare to have subclavian injury and blunt trauma. It exists, but it's not as frequent as penetrating like this case.
Awesome, thank you. I'm just going to ask for Dr. Kassim input as well, and then we can move on with the case, and I can call the next panelists in a second portion of the case. Dr. Kassim, any comments on that? Any different ideas? I think Dr. Kassim is muted.
There's a
Kevin,
request in the chat to see the scan again too, Dr. Menegoza.
Oh, yeah. Okay, great. Thank you, Kevin.
So Dr. Rodriguez is kind enough to teach us the importance of the zone. But what is really important in a case like this is the patient stable or unstable? That's the first thing you want to know. And also, is there any other associated injuries that you may be overlooking? I mean, this is a penetrating injury via bullet. Did it get any other organs in the neck, such as the trachea, the esophagus? I think these needs to be addressed as well. And having put the chest tube in, you got 1.5 liters. And then after that, what is the nature of the output from that chest tube? That will determine whether you are rushing to the operating room or going to the CT scanner. The worst thing you can do in a case like this is when somebody is hemorrhaging, take him to the CT scanner, because surely that he's going to die in the scanner. So having said that, what is the most appropriate methodology in a case like this? We're not talking about the left side, we are mainly talking on the right side. And I think as a young surgeon, as you are developing your clinical expertise and operative acumen, and you need to have a plan before you have this patient in the grip of dying from hemorrhage. And you need to know what exactly are you going to be doing and why you are going to be doing that particular procedure. If you're going to save this patient's life, the first thing you need to do is to stop the hemorrhage. And there are tools available for us at this moment. Sometimes, if you can thread a Fogarty catheter or a balloon catheter and get a balloon occlusion to stop the hemorrhage, that's a good maneuver as well. And again, it will determine the location of the injury. I personally do not like just doing a subclavicular incision on the right side. I think I would like to start with the sternotomy and then angle it to the right side, so I have a panoramic view of what is happening to the patient. And that is my approach. And so far, that approach has not failed me. Thank you.
That's great. So I think we can move on a little bit, and then we can ask for the other panelists as well to make their comments.
Okay. So after his original chest tube put out the 1.2 liters, it actually wasn't putting out anything else. And he was still hemodynamically stable. This was just the coronal view of his CTA, which shows the same thing with the abrupt cutoff, and then he has reconstitution distally. We brought the patient back to the trauma bay, and after seeing this, we thought that he may have had a thrombosis of his injury, and so we consulted our vascular surgeons, and we elected to do an endovascular repair. On the way to the operating room, I think whatever clot that he may have had may have popped off because he started to have increasing output from his chest tube, as well as required more blood products. So we went to our hybrid operating room with the intent that we would try to get a balloon occlusion up. If we were unable to do so, then we were going to do a median sternotomy. And these were our intraoperative pictures. I don't have one from before we were able to get a wire across, but you can see that he had a complete transection. We were able to get a wire across the lesion. And then you can see where he has some contrast extrav into his right chest. This is the same picture. And this, we were able to get a stent across his subclavian artery. It actually took 2 stents to completely occlude the injury. And then this was our completion angiogram. During our completion angiogram, you can also see that he has significant hemothorax with collapse of his right lung. He remained hemodynamically stable, so we tried to suction out and irrigate as much of his right chest as we could, and then replaced our right-sided chest tube.
Dr. Cage, Dr. Wagner, can you walk us through how you did this irrigation, using the drains, and how did you exchange the drain? What did you do in this case?
So Dr. Wagner actually uses our thoracic irrigation that we use here. We did not during this case. We removed our chest tube. We tried to use a Yankauer suction to get out as much of the hemothorax as we could. And then we had a completion x-ray, which showed resolution of the hemothorax. So then we just irrigated through that. For some reason, we couldn't get the suction irrigator to work, and we didn't want to extend our incision. And then at the end, we replaced our chest tube.
There are multiple ways to do the suction irrigator. We have the commercially available one here, but due to the IV fluid shortage here, we had to go back to the old school style. So I actually, in the past month, have done this twice. But what I'll do is I'll take a bulb syringe, pop the bulb off. So then you just have the plastic tube, feed that into the end of your chest tube, and then you can pour in IV or normal saline into the chest. So we were doing 500 cc aliquots. So I would use that plastic part as like a funnel to pour in 500 cc's, wait, and then I would take a Yankauer tip attached to my suction and then put it in the end of the chest tube and suction it out. And based on our protocol here, we do it 500 cc increments for a total of 2 liters, as long as things are rinsing clear. You can obviously do more, but for us, 2 liters is a good kind of check mark for us to say, should we still be doing this, or do we need to extend our incision and do a thoracotomy and make sure that there's not something else bleeding in the chest? So there are 2 ways to do it in case you don't have the commercially available suction irrigator as well.
Yes, and just to make sure, you are using in the 2 occasions you used conventional tube thoracostomy, right? Not a pigtail.
Correct.
Correct.
Yeah, 28 French.
Oh, 28. Okay, thanks.
We have thoracically irrigated here at our institution through a pigtail.
Mhm.
And there are other institutions that have shown that you can do that adequately. We're just more comfortable with the 28 French tube, and two, if you don't suture it in, you can kind of push the chest tube in and out and kind of like change the direction of the chest tube. So that way you're irrigating the entire thoracic cavity and not just that dependent portion where you lay your chest tube.
Okay, great.
And we have found better results, I think, when we didn't suture it in prior and we were able to kind of move our chest tube around to direct where we want it to go.
Perfect. Okay, I think you can move on.
So post-operatively, the patient got an MRI, which showed severe canal stenosis, and he had a T3 to T5 ligamentous injury. He did well post-operatively. He was extubated on post-op day 4. On post-op day 9, we got a repeat CTA of his chest, which showed a right pulmonary pseudoaneurysm for which IR embolized. And on post-op day 12, he ended up getting a right VATS with a decortication for retained hemothorax. But ultimately he was discharged to rehab on post-op day 20 and has since been discharged from rehab and is at home.
Great. I wanna ask something for ask a question actually to Dr. Untracht. So, Dr. Untracht, I'm looking at this slide and I'm wondering about the retained hemothorax. So, do you have any tips for any ways that we can avoid the retained hemothorax? Number one, and number two, how to diagnose this very, very early to make sure we can address this in a good way.
Yeah, I think that just as the doctors did here, you know, they addressed it very early with irrigation to remove the hematoma. They put the Yankauer suction catheter directly in the chest to evacuate the retained clot. But you know, I think this case just underscores how important it is to evacuate all of the hemothorax early. And despite all of the efforts that were directed here to clearing the chest, the patient still developed a peel and needed a decortication. But at least now you can do it through thoracoscopy and not, as in my day, a big old incision that is highly morbid. But I don't have any other suggestions other than what these good surgeons did.
Yeah, and Dr. Wagner and Dr. Cage, do you have in your institution any protocols that might try to find patients that are more that have more risk of having this kind of situation, and maybe you try to develop some type of protocol to get these patients to the, I don't know, X-ray, ultrasound, or CT scan in a like very, very fast? Do you have anything that you could share with us in that sense?
We do have a chest tube protocol here. So any patient that has a chest tube gets a daily chest x-ray just to monitor for pneumothorax and retained hemothorax. And then typically, if we're not seeing a resolution of that hemothorax by 48 to 72 hours, the patient will get a dry or non-contrasted CT chest just to make sure that we're adequately draining everything. And then that kind of dictates time to VATS or possibly a later thoracic irrigation. We also have a thoracic irrigation protocol here. So any patient that has more than 300 cc's of retained hemothorax, that's with or without the presence of a thoracostomy tube on CT or chest x-ray prior to the IV fluid shortage, would get thoracically irrigated. So we saw kind of a decrease in the number of our retained hemothoraxes because of that, but now in this shortage, we'll see what our rates do. But prior to all of this, I would say our thoracic irrigation protocol and then our chest tube protocol for daily chest x-ray through 72 hours, and then a dry CT at 72.
That's awesome. Thanks. I think you can move on. You have another case, right?
We do. Similar, but not the same.
Can we
Yeah.
do some commentaries about this case?
Sure, of course, Dr. Elio.
Okay. Yes, I mentioned that if the situation is different, you have to go and take the patient to the OR or do something. But I have a question or I have a concern. You have a patient with an injury in the second portion of the subclavian, correct? And it's stable, quote unquote. So that tell you to call somebody to do the endovascular approach in this case. Okay. Of course, I am from a generation that's very easy, despite I wasn't the intergalactic trauma center who has an angiographists waiting for me to do it before even patient arrived, you know, we decided to do something different. Now, I will not do it if it's zone 2. I wouldn't have to do an sternotomy. Dr. Think I don't argue with him. You know, that's the way that he's successful in those cases. I have done the one I have done just the patient is stable, take the clavicle or put the clavicle up and repair and the subclavia, take care of the subclavia there. So this case, you did that. I try to understand. Now, you're telling me in the meantime, the patient basically drained a lot of blood coming out. It didn't scare you that because one thing I understand and I understood, I learned for my mistakes, is you go where the money is. You're telling me that he got a chest tube draining like crazy, you know, at one point, you know, and for me, that would be an indication in that moment to do a thoracotomy, you know, and because you're telling me that eventually you have a pulmonary artery aneurysm where you haven't say much about that. You say, oh, well, he has a pulmonary artery aneurysm who can blow out, you know. So maybe at one time I will be able to find that. And in my case, I have that it wasn't the wrong cavity, you know. I learned that you had to go where the money is. So you start exsanguinating the right chest. I opened the right chest to see what's going on. And there was the subclavian. I was able to put a balloon catheter through that and stop the bleeding and then make a decision what to do. So in this case, seems to everything did well with the endovascular. Now, this was done retrograde because there are two ways to do it: retrograde or antegrade. At retrograde is for the femoral, antegrade is for the brachial. The endo repair people do that way. In this case, was retrograde. I guess was the preferred thing to do. So I think this is an interesting case, you know, but I was still one concern about that the cavity, the chest cavity need to be open. Now I had to make a comment. I was reviewing because I had to review my license. In spite I'm retired, I want to have my license on in case, because I'm a hypochondriac, I had to prescribe myself and do CAT scans every week. You know, I review and I found a lot of articles about washing the chest. That's exactly what you're saying, you know. Now they don't open, they just wash it out and everything is fine. I said, Jesus is back here in Earth, despite the president. And, you know, this everything is becoming easy, you know. In my generation, as the doctor said, we used to open and do the cortication and stuff like that, but or be more aggressive. So you think that washing the chest seems to be did a good job here. It seems it works. Good case.
Okay. Our
Yeah.
second case.
Yeah, sure. Go on.
This is a 34-year-old male status post GSW to the right back. EMS noted that he was in respiratory distress en route and he was placed on a non-rebreather. Upon auscultation of his chest, they felt like he did not have breath sounds on the right. So he was actually needle decompressed in the field through the right second intercostal space mid-clavicular line. Primary survey, he was hemodynamically stable, otherwise en route, and hemodynamically stable in our trauma bay with systolics in the 120s and a heart rate in the 60s. However, his O2 saturation was 95% on rebreather with the needle decompression needle, which is denoted as that T on our figure. His airway was intact. He still had diminished breath sounds on the right, but per EMS were improved after the needle decompression. Originally, he did have palpable right upper and left upper radial pulses that were symmetric bilaterally. His GCS was 15, and then there was a ballistic wound noted in the right back, and then which is denoted by the X on the figure, and then the O on the figure was a palpable ballistic that we could feel within his right neck. However, during our secondary survey, we did have a change in his neurovascular exam. He started having diminished motor and sensation in his right upper extremity, and he went from having a palpable right radial pulse to then having a pulseless right upper extremity, and we were unable to get a Doppler signal at that time. We completed an EFAST, which showed no lung sliding on the right, so we proceeded with a chest X-ray, which, as you can see from this chest X-ray, he has a large right hemothorax, and then you can see that retained ballistic in his right neck. During this chest X-ray, I noted pulsatile bleeding coming from the needle decompression needle. So I placed a cap over the needle decompression needle at that time. The patient, however, remained hemodynamically stable throughout this entire time. And due to concern for vascular injury, we decided to, and this may cause some controversy, defer chest tube placement at that time because we were concerned about decompressing the right chest and the patient is sanguinating due to a possible subclavian injury. Because the patient was hemodynamically stable, we did take him urgently to the CT scanner for further imaging and operative planning. I wanted to pause here to ask people's opinions because I know that this is a very controversial opinion to not place a chest tube at this time. I wanted to know if some of the other people in the crowd would have placed a chest tube and then proceeded to the operating room endovascularly or open based on the chest tube output, given that the patient was still hemodynamically stable.
Yes, interesting. So let's ask Dr. Kassim. Dr. Kassim, what are your thoughts on that? I think Dr. Kassim.
How old
okay.
was this patient? I didn't get that.
How old?
Yeah.
34.
34. Well, I think you're getting false information. He's well compensated because he's so young.
Mhm.
And even though that your readings show that hemodynamically stable, I still would have put a chest tube in because that's the right thing to do before you take the patient to a CT scanner. Because you don't want to go to a CT scanner without some type of a decompression of the right chest when a patient is having some respiratory problem, and also you may be getting the false information about his hemodynamic stability because he's well compensated.
Yes, sir.
Yeah. Dr. Untracht, any other thoughts?
Yeah, I agree. I would have put the chest tube in because all you're doing, he's still bleeding, whether there's a chest tube or not. This is a rotated film, but it looks as if the heart's shifting to the left, but it's probably because of the rotation. But eventually that would be what would happen if he's bleeding arterially at a high pressure into the chest. Eventually he'll get a tension hemothorax. So I would want to have the chest tube in, and if the bleeding is too much, then that would force me to choose the operating room rather than CT. But if you put the chest tube and he's still hemodynamically stable, then you can go with confidence to the CT scanner. But apparently, this worked anyway for you, so it worked in this case.
So we proceeded.
Can I make a comment?
Oh, yes, sir.
Sure, Dr.
Two comments, actually. Number one is I think everybody will put chest tube here, because that's the reason you guys all mentioning. It takes 2 minutes or 3 minutes to put a chest tube. You know how to do it very quickly, without infections. And then they will tell you one thing. They will tell you, as we said, if chest tube is exsanguinated to death, then you take the patient to the OR, correct? It's different if we're saying the same thing. Chest tube, yes, no question about. Second, the second comment is This business, I remember 30 years ago, 40 years ago, whatever, I was doing this. You know, the pre-hospital care providers start putting needles, so they compress. That was absolutely dangerous. You know, I have seen poop coming out through the needle. They perforate the colon. There was a hernia, the colon was there was no pneumotor. They didn't hear the sound, so they say, oh, it's a pneumotor. It's the poop that come out through the. In this case, iatrogenicus imperfectus, they can hit the subclavian. I never found that, I know it's in all the books of pre-hospital care, but I would like to hear the opinion of the experts here, the older people like me. What do you think about this decompression? Everybody talk about put a needle decompress. It's the same like pericardiotomy, you know? I have a patient, I have a fellow who drain the pericardium and say, Dr. Rodriguez, you see, I'm from Johns Hopkins, you know? And so I put a needle, I get this compressed. I said, yeah, but look at that. Your needle is in the lung, it's not in this. So he was from Hopkins. Okay, so tell me, I would like to listen to the opinion of the doctor regarding the decompression of the needle.
Dr. Untra, Dr. Kasim, any comments on that?
Yeah, I would just say, look, the needle, you know, exactly as Dr. Kasim just put in the chat, there's a high failure rate, especially in young muscular guys that get the shot like this, that pump a lot of iron, that, you know, if you put it in the anterior axillary line, it doesn't go in the chest, then the muscle layer is too thick. So it should be at the fourth interspace laterally, the mid axillary line. And, you know, just to decompress a tension pneumothorax, but, you know, that would be the only difference that I would recommend.
This needle was placed in the pre-hospital. I thought that's what he said. It was put in the hospital.
Pre-hospital, it's placed by EMS.
Yeah, I never seen in the hospital anybody putting needles. Okay. It's very hard to do anyway.
Okay. Dr. Kasim, any comments, or should we move on?
No, they do. The EMS do put needles in. Sometimes they're very successful, and I shall not criticize them. But the correct place to put this needle is mid-axillary line, as high as possible. What you do is you have the needle in your right hand, put the left palm in the axilla and aim for the mid of your palm, and that's where you put the needle in. You don't have to count. You don't have to go here and looking for everything. And also try to use the largest needle, because our population is getting well endowed with a lot of fat.
I think you're a needle man, Dr. McKee. I mean, what state do you are that they are so good, you pre-hospital care provider? Which state you work?
I'm in Oregon.
Oh, maybe they are very good there. I tell you, in Maryland, I see disasters with the needles. Maybe it was a long time ago, you know, when the beginning of they start putting, they were not as good as recently, you know, they are better, I guess, now.
Okay, Dr. Wagner, I think you can move on.
So we took the patient to the CT scanner. As you can see, there is a blush in the proximal second portion of the subclavian, and then the patient obviously does have a very large pneumothorax on the right. And of note, the needle decompression needle was in the correct spot. So we contacted our vascular surgery colleagues for a possible endovascular repair of the subclavian artery injury. And so we went to our hybrid suite. And then due to concerns for hemodynamic collapse on induction, we opted to get right femoral artery access under local anesthesia with the intention of gaining proximal control with an excluder balloon before intubation. So you can see here, we have our catheter up, and you can see that there is a no contrast filling across the subclavian. And then let me see if I can read to, maybe not. There is delayed. Why is it not going? There is very delayed filling of the distal subclavian and then proximal axillary artery on this initial scan. And then on this film, you can see we do have a blush from this proximal portion of the second portion of the subclavian on our initial angio runs. So we were able to get up our excluder balloon proximally, and with that, we had no more contrast extrab through the subclavian. And as you can see on these initial angio runs, there is still this very large right-sided pneumothorax with compression onto the right lung. At this time, the patient became agitated and desaturated and was intubated. A right chest tube was placed urgently, and 3.3 liters of blood was initially evacuated out of the right chest. After that initial evacuation, there was approximately 50 cc's or so throughout the rest of the case that was coming from the right chest. So next, after we had our excluder balloon up, we tried to pass a wire, and we were unable to pass the wire anterograde down the artery. It kept on coiling. And so we ended up doing a right brachial artery cut down and passed a wire retrograde in the rendezvous procedure.
You mean antegrade, right? Or retrograde?
Retrograde, sorry, we couldn't pass the wire anterograde, and then we did the brachial artery cut down and were able to pass the wire anterograde or retrograde, sorry. So as you can see in this picture, we do have our catheter across the defect, and we have this obvious extravasation of contrast, but we do have our catheter and our wire across the defect. So we were able to then place a stent across the area of the defect and completely exclude this injury. We noted that there was brachial artery flow at the end of the case, and the patient had pulses in multiphasic radial and ulnar signals at the end of the case that were not present at the beginning of the case. After we had gotten our stent across, we proceeded with thoracic irrigation. On initial aspiration of the chest, even after evacuating the 3.3 liters of blood, we got an additional 800 cc's that had pooled in the chest during the case. We irrigated with 3 liters and evacuated 3,900 cc's after the irrigation of 3 liters. So a total of 5 liters of blood was ultimately evacuated from this patient's chest. And as far as his postoperative course goes, he had full motor and sensation immediately post-op. On post-op day 7, he had to have his chest tube reinserted for a hemothorax. It was thought to be due to bleeding from a right upper lobe lung laceration. On post-op day 12, the chest tubes were removed, but his hospital stay was complicated by pneumonia, for which he was treated. And then he was discharged on hospital day 12 home on aspirin and Plavix for his antiplatelet stent management.
Dr. Wagner, there's a question on the chat from Dr. Edmund Burke. He's asking if the patient was heparinized after the stent.
He did receive heparin in the operating room just once during our brachial cut down, but after that, no. He just started aspirin on post-op day 1.
And did you use any type of auto transfusion for these patients? Maybe both cases, actually, case number 1 and number 2.
No, he actually got no blood in the trauma bay, no blood in the operating room, and then when he got up to the ICU, his hemoglobin was actually 10, so we did not transfuse him then. We got a TEG as well, and his TEG was not abnormal, so he got no type of blood product in his initial 24-hour perioperative resuscitation.
Wow, that's surprising. Dr. Kasim is asking if the stent that you placed was a plain stent or a covered stent.
It was a Viabon.
Okay. Dr. Untracht, any comments on the case?
No, great case, terrifically done. And just a question. So, you know, when you repair these injuries operatively, often, you know, you have clots distally and you don't have good flow initially, and you need to run Fogarty catheters. So how does the procedure work when you do this in the interventional radiology suite? Can you do the same thing? Can you run catheters and remove clots? And you know, what would be your approach here if you didn't get reestablished flow immediately?
We do have an overwire Fogarty that's available here. Typically, we only get to participate in these endovascular cases when it's at nighttime or when we're on the vascular service. So I'm not as familiar with the endovascular approach, but in the cases where we have had to do a brachial artery cut down as well, we'll send Fogarty's down through our arteriotomy.
Mm-hmm. But great case, well done.
Can I make a comment?
Yes,
Of
sir.
course, Dr.
Yeah, I can see that your two cases seem like you use your hybrid. Is that that you use it very often? Seems to be that you have a lot of use of the hybrids. Question to the audience is, I'm old and I don't know, I'm retired, so I don't know, until recently, there were not many, everybody talked the hybrid, but I feel a few hospitals had hybrids. So I guess everybody has a hybrid, you know. There is in Pennsylvania, a Dr. Rogers, who writes all the time. You know, he has a hybrid, he's division 2, level 2. It's a level 2 trauma center, and he has a hybrid. Some rich guy donate a hybrid. So Emory seems to be that is something new, or you have it for a while, this hybrid, the question. Doctor?
I think we've had it for a while, but we do utilize our hybrid room a lot here.
I think it's when Feliciano or Rosicky were there, I don't know, they were having. But anyways, it's a good stuff to have. I was going to make a comment that apparently the advantage of the endovascular repairs, that's what I read to be able to take my license, you know, is two. Number one, they claim that it can be done faster, particularly that to open, repair, and second, there is less consumption of blood, you know, because obviously it's less bleeding when they do endovascular. I don't know, that's important to know, but it's a question I'm sure they will ask in the board, you know, what's the advantage to do one versus the other? One is, you know, it's faster to do, and the second is you save blood, you know. I don't know.
I actually looked at our skin to skin time for this case, and it was 122 minutes.
Except that you never learn how to do this, the real thing here. That's bad. You know, we went through we had to open and repair, and it's nice, you know. Well, you would be a good endovascular surgeon, trauma guy.
So Dr. Ellaby told us in the chat that he believes that they have the hybrid OR since 2020. Okay. Yeah, when I saw the subject, Dr. Aurelio, I thought that we were going to see like open thoraces and a lot of blood and everywhere, but it was really interesting to see both cases managed.
Those days are gone.
Yeah.
And now the artificial intelligence improves, the machine will repair, you know, that.
Yeah. Well, that was really, really nice. So, okay, great. So, Dr. Wagner, Dr. Cage, thank you very much for presenting these cases. We hope to see you both lots of times here with us in the meeting in the future as well. And please, if you like to present any more cases, just get in touch with me or via Dr. or via Alejandro, and we can arrange the next meetings for you guys to present more cases. So I want to thank Dr. Untracht, Dr. Aurelio, and Dr. Kasim for the comments. And I saw that there are a lot of people here in this meeting today. We have a full house actually, and I'm really sorry I couldn't call everyone to comment because it's a lot of people. But I'm hoping to see everyone in the next meeting so I can maybe call other panelists as well and make sure we have a nice discussion, very interesting case discussions. So I thank you very much, all of you.
I
And I hope
have
to
just I have a question for Dr.
Sure.
personal question for Dr. Cassim. Maybe I just want to. I trained with somebody from the state you mentioned. You know, his name was Dr. Dupriest. Is he alive? You know any trauma surgeon Dupriest? He was a fellow.
Yes, I do.
What happened to him?
He worked in Eugene, Oregon, and he retired. And
He was a
he's
fellow
a
with
good
me in
man.
1976 in shock trauma, 76, and
Right.
he was famous because this is an anecdote, you know, and the unit we have a receiving unit in shock trauma, the original thing, you know, two beds only in the reception and 4 ICUs. X-ray technician argued with him, and he punched the X-ray technician. One shot, the technician fell on the floor, and then they had to resuscitate the technician and not the patient, you know. That's the story. If you ever talk to him, tell him, I haven't known about him for 40 years, you know, Dr. Dupriest. We call him Rocky.
That's funny.
All right.
Thank you.
Oh,
All for
just
including us.
yeah, thank you. Just a quick comment, Dr. Chris Ramos sent in the chat. Immediate complications include undersizing the stent, as patients can come in vasoconstricted. These patients require an extension with a larger stent. There have been delayed presentations of thrombosis, but patients asymptomatic. Okay, that's interesting. A nice discussion about endovascular treatments as well. Okay, everyone, thank you very much once again. I hope to see you in the next week for the next meeting, and I hope we stay in touch. Bye-bye.
Thank
you all.
you.
Thank you.